Good morning, class. So today we're going to be going over Chapter 22, Psychiatric Emergencies. Introduction. EMTs often care for patients experiencing a behavioral crisis or a psychiatric emergency. Crisis may be the result of acute medical situation, mental illness, mind-altering substances, stress, or many other causes. Myth and reality. At some point, most people experience an emotional crisis. This does not mean that everyone develops mental illness. Do not jump to conclusions concerning yourself or your patient. The most common misconception is that if you are feeling bad or depressed, you must be sick. There are many justifiable reasons for feeling depressed: divorce, loss of job, death of a relative or friend. Another myth is that all individuals with mental health disorders are dangerous, violent, or unmanageable. Only a small percentage fall into these categories. EMTs may be exposed to a higher proportion of violent patients. Many people believe that all individuals with mental health disorders are dangerous, violent, or unmanageable. Communication is key. Patients may de-escalate when a level of trust is established. You may be able to predict violence. So defining a behavioral crisis, behavior is what you can see of a person's response to the environment, his or her actions. Most of the time, people respond to the environment in reasonable ways. Over time, people learn to adapt to stress. Sometimes the stress is so great that the normal ways of coping do not work and a crisis occurs. A behavioral crisis or psychiatric emergency may involve patients who exhibit agitated, violent, or uncooperative behavior or who are in danger to themselves or others. EMS is called when behavior has become unacceptable to the patient, family, or community. If an abnormal or disturbing pattern of behavior lasts for a month or more, it is a matter of concern. When a psychiatric emergency arises, the patient may show agitation or violence, may become a threat to self or others. The magnitude of mental health disorders. Mental health disorders are common throughout the United States, affecting tens of millions of people each year. A psychiatric disorder is an illness with psychological or behavioral symptoms that may result in impaired functioning. Anxiety disorders. Generalized anxiety disorder, panic disorder, social and other phobias, post-traumatic stress disorder or PTSD, obsessive compulsive disorder or OCD. The U.S. mental health system provides many levels of assistance. Most psychological disorders can be handled through outpatient visits. Some people require hospitalization and specialized psychiatric units. Psychiatric disorders may have underlying causes, social and situational stress, such as divorce or death of a loved one, diseases such as schizophrenia, physical illness such as diabetic emergencies, chemical problems such as alcohol or drug use, biological disturbances such as electrolyte imbalances. So an EMT is not responsible for diagnosing the underlying cause of behavioral crisis or psychiatric emergency. Two basic categories of diagnosis: organic and functional. So remember, it's not your job to diagnose what kind of behavioral crisis or psychiatric emergency the patient might be experiencing. The responsibility is to make sure that you're safe, your partner is safe, and the patient is safe, and transport them to the appropriate facility to get them cared for. So organic disorders, organic brain syndrome, temporary or permanent dysfunction of the brain caused by a disturbance in the physical or physiologic functioning of the brain tissue. Causes may include sudden illness, traumatic brain injury or TBI, seizure disorders, drug and alcohol abuse, overdose or withdrawal, and diseases of the brain. So functional disorders. Physiological disorder that impairs bodily functions when the body seems to be structurally normal. Examples: schizophrenia, anxiety conditions, or depression. Safe approach to a behavioral crisis. All regular EMT skills are used in behavioral crisis. Other management techniques are also involved. Scene safety. Consider the scene safety and the patient's response to the environment. Take appropriate standard precautions. Request any additional resources you may need early. So if you think you're going to need PD for a call, you can go ahead and request them right away. And also make sure you have an out. Make sure you're not standing. The patient's not standing between you and the only way out in case things get violent. So always make sure you have a way out. So mechanism of injury, nature of illness. Note any medications or substances that may contribute to the complaint or be treatment of a relevant medical condition. So primary assessment, form a general impression. Begin your assessment from the doorway or from a safe distance. Perform a rapid physical exam. Observe the patient closely. Establish a rapport with the patient. So airway and breathing, circulation, transport decision. Unless the patient is unstable from a medical problem or trauma, prepare to spend time with the patient. You could go ahead and reassess the patient, talk to the patient, find out if there's anything going on in their personal life, work life, anything like that. History taking. Investigate the chief complaint. 3 major areas to consider. Is the patient's central nervous system functioning properly? Are hallucinogens or other drugs or alcohol a factor? Are significant life changes, symptoms, or illness involved? Sample history. You may be able to elicit information not available to the hospital staff. Use reflective listening. So questions to ask in evaluating a mental health disorder. And it's a table with a couple questions for you guys. Does the patient's behavior seem appropriate? Does the patient seem to understand you? Is the patient withdrawn or detached, hostile or friendly? Does the patient seem aggressive or dangerous to you or others? Is the patient's memory intact? Check orientation. ANO times 4. Does the patient express disordered thoughts, delusions, or hallucinations? Patient may be put on a 5150 hold. You may need to request PD for that. So, secondary assessment, physical examination, and an unconscious patient begin with a physical exam. A conscious patient may not respond to your questions. You can tell a lot about a patient's emotional state from facial expressions, pulse rate, and respirations. A blank gaze or rapidly moving eyes can mean central nervous system dysfunction. Transport decision. Have law enforcement or firefighters accompany if possible. Take the patient to a facility capable of caring for patients with psychiatric problems. Transport the patient by ground. So reassessment. Like I said before, never let your guard down. Make sure you have a way out. Make sure you guys stay safe at all times. If restraints are necessary, reassess and document every 5 minutes. Respirations, pulse, motor, and sensory function in all restrained extremities. So check CSM in your restrained extremities before and after, and recheck every 5 minutes. Because you're going to have to put those restraints on somewhat tightly. You want to make sure the circulation is not cut off for the patient. So interventions, diffuse and control the situation. Intervene only as much as it takes to accomplish these tasks. If you think a pharmacologic restraint is necessary, request ALS assistance as early as possible. So if the patient's being combative, as a paramedic, I give Versed. It's usually either given IM or IV to a patient to help calm them down, to help protect you and your patient. So communication documentation. Give the receiving hospital advance warning of the psychiatric emergency. Document thoroughly and carefully. If restraints are used, identify which types and why they are used. Acute psychosis. Psychosis is a state of delusion in which the person is out of touch with reality. Affected people live in their own reality of ideas and feelings. Schizophrenia is a complex disorder that is not easily defined or treated. Symptoms and signs: delusions, hallucinations, a lack of interest and pleasure, erratic speech. Guidelines for dealing with a psychotic patient. Determine if the situation is dangerous. Clearly identify yourself. Be calm, direct, and straightforward. Maintain an emotional distance. Do not argue with the patient. This may cause the patient to get more agitated, possibly become more aggressive and violent towards you. So explain what you would like to do. Involve people whom the patient trusts, such as family or friends, to gain the patient's cooperation. So if there's someone on scene, a family member, a friend, anybody that knows the person, you could talk to them and let them know what you need from the patient. Keep them calm, keep them safe. So excited delirium. Delirium, a condition of impairment in cognitive function that can present with disorientation, hallucinations, or delusions. Agitation, behavior characterized by restless and irregular physical activity. So symptoms: hyperactive, irrational behavior, vivid hallucinations, hypertension, tachycardia, diaphoresis, dilated pupils. So be calm, supportive, and empathetic. Approach the patient slowly and respect the patient's personal space. Limit physical contact. Patients sometimes don't want to be touched. They don't want you to get too close to them. You got to establish some rapport with the patient. And also do not leave the patient unattended, especially if they're being violent or aggressive. Use careful interviewing to assess the patient. Observe the patient's ability to communicate, appearance, dress, and personal hygiene. If the patient has overdosed, take all medication bottles or illegal substances to the medical facility. So remember, we talked about this last chapter. You want to make sure you take all the medication bottles that patient may have taken. If you think patient has taken more than one pill or one medication, take them all. Let the doctor figure that out. They're going to do some labs once they get there. And the doctor's going to figure out what they want to do for the patient. So they want to know all the medications or substances that patient may have possibly taken. So if the patient's agitation continues, request ALS assistance so chemical restraint can be considered. Uncontrolled or poorly controlled patient agitation could lead to the patient's sudden death. So restraint. Every pre-hospital care transport provider should create and follow a pre-hospital patient restraint protocol. Protocols vary widely. The restraint chosen should be the least restrictive option that ensures the safety of the patient and providers. Personnel must be properly trained. If you restrain a patient without authority in a non-emergency situation, you expose yourself to a possible lawsuit. Legal actions can involve charges of assault, battery, false imprisonment, and violation of civil rights. So make sure, if you restrain a person, make sure it's for your own safety and for the safety of the patient. If the patient is alert and oriented times 4 and they're not on a 5150 hold, they can't be legally taken to the hospital. They can't be thrown in restraints. That's considered kidnapping. So be very careful when you're dealing with an agitated patient. Make sure that the patient does want to go to the hospital or the patient is on a 5150 hold. So you may use restraints only to protect yourself or others from bodily harm, to prevent the patient from injuring himself or herself. So they talk about the least restraint necessary to control the patient. So that's what you guys have to keep in the back of your mind to make sure that the patient stays safe and you stay safe. So involve law enforcement if the patient is in a severe behavioral crisis or psychiatric emergency. Before considering physical restraint, use verbal de-escalation techniques. Process of restraining a patient. Carry out the decision quickly. There should be 5 people to help, 1 responsible for each extremity, 1 responsible for the head. There should be a team leader and plan of action. Use a minimum force necessary. So don't go above and beyond when you're restraining a patient. Use a minimum force. You don't want to also injure the patient while you're putting on restraints. Make sure you have extra hands on deck. The level of force will vary depending on these factors: the degree of force that is necessary to keep the patient from injuring himself and others, the patient's sex, size, strength, and mental status, the type of abnormal behavior the patient is exhibiting. Talk to the patient throughout the process. Let them know what's going on. Let them know that you're putting them in restraints. It's for the safety of them and you. If you explain to patients that way, they might calm down a little bit. They might be a little less agitated, Treat the patient with dignity and respect. If possible, a provider of the same age should attend the patient. Wear appropriate barrier protection. So avoid direct eye contact and respect personal space. Never leave a restrained person unattended. 4-point restraints, both arms and both legs are preferred. Monitor the patient closely. So in our county, we have to do, for anyone 5150, 4-point restraints. So it means both arms and both legs. We're going to put the patients in restraints. So a potentially violent patient. Violent patients make up only a small percentage of patients undergoing a behavioral or psychiatric crisis. Be alert for signs of potential violence. History. Has the patient previously exhibited hostile, overly aggressive, or violent behavior? Posture. How is the patient sitting or standing? Is the patient tense, rigid, or sitting on the edge of his or her seat? So the scene. Is the patient holding or near potentially lethal objects? So is there a knife near the patient? Is there a gun near the patient? It's something you guys have to consider for scene safety, especially if the patient looks like they are agitated or may get agitated. That's something you guys have to take in concern. And also request PD. So vocal activity. What kind of speech is the patient using? Loud, obscene, erratic, and bizarre speech patterns usually indicate emotional distress. So physical activity, most telling factor of all. Patient requiring careful watching is one who has tense muscles, clenched fists, or glaring eyes, is pacing, cannot sit still, is fiercely protecting personal space. Other factors to consider: poor impulse control, history of truancy, fighting, and uncontrollable temper, history of substance abuse, depression, functional disorder. So suicide. Depression is the single most significant factor that contributes to suicide. It is a common misconception that people who threaten suicide never commit it. Be alert to these warning signs: air of tearfulness, sadness, deep despair, or hopelessness. Avoiding eye contact, speak slowly, and project a sense of vacancy. Unable to talk about the future. Suggestion of suicide. Having any plans related to death. So here's a small table. Risk factors for suicide. Specific plan. Family history of suicide. People older than 40 years. Particularly a single, widowed, divorced, alcoholic, or depressed. Recent loss of spouse, significant other. Family member support system. Feeling anxious. Financial setback. Loss of job. Alcohol and substance abuse. So all things to consider. Consider these additional risks. Are there any unsafe objects nearby? Is the environment safe? Is there evidence of self-destructive behavior? Is there an imminent threat to the patient or others? Additional risk. Is there an underlying medical problem? Are there cultural or religious beliefs promoting suicide? Has there been trauma? A suicidal patient may be homicidal as well. So anybody who makes any threats regarding wanting to harm themselves or wanting to harm others is going to be placed on a 5150 hold. And it's important to relay that to the medical staff, the nurses, the hospital, the doctors, if a patient says something to you like that. So post-traumatic stress disorder and returning combat veterans. PTSD occurs after exposure to or injury from a traumatic event. An estimated 7 to 8% of the general population will experience PTSD at some point in their lives. Military personnel with combat experience have a higher incidence. Symptoms of PTSD include feelings of helplessness, anxiety, anger, and fear. People with PTSD may avoid reminders of the trauma, suffer constant nervous system arousal, can relieve the traumatic event through thoughts, nightmares, and flashbacks. Veterans have an increased risk of suicide. Veterans may develop a variety of physical conditions related to combat injuries. Combat veterans have a higher incidence of traumatic brain injury or TBI. Caring for the combat veteran requires a unique level of understanding. Be careful how you phrase your questions. Use a calm, firm voice, but be in charge. Respect the veteran's personal space. Limit the number of people involved. Ask about suicidal intentions. Caring for the combat veteran. Ensure that there is nothing the patient can access and use as a weapon. Physical restraints may simply escalate the problem. So medico-legal considerations. More complicated with the patient undergoing behavioral crisis or psychiatric emergency. You must decide whether the patient needs immediate emergency medical care. The patient may resist your attempt to provide care. Never leave the patient alone. Request law enforcement personnel to assist the patient. Consent. Implied consent is assumed with the patient who is not mentally competent to grant consent. Consent matters are not always clear-cut in psychiatric emergencies. If you are not sure, request the assistance of law enforcement personnel or guidance from medical control. So limited legal authority. The EMT has limited legal authority to require a patient to undergo emergency medical care when no life-threatening emergency exists. Competent adults have the right to refuse care. So anybody who's ANO4 and is not on a hold or who's not under a conservatorship has the right to refuse care. Make sure you know your county protocols. Make sure you know the laws before you start providing care to somebody. You're putting patients in restraints. In psychiatric cases, a court of law would probably consider your actions in providing life-saving care to be appropriate. A patient who is in any way impaired may not be considered competent. Maintain a high index of suspicion about the patient's condition. Err on the side of treatment and transport. So review. A behavioral crisis is most accurately defined as a severe acute psychiatric condition in which the patient becomes violent and presents a safety threat to self or others. B, any reaction to events that interferes with the activities of daily living or who has become unacceptable to the patient, family, or community. A normal response of a patient to a situation that causes an overwhelming amount of stress, such as loss of a job or marital problems, or a reaction to a stressful event that the patient feels is inappropriate but is considered inappropriate by the patient's family or the community. So B, a behavioral crisis is any reaction to events that interferes with patient's activities of daily living or has become acceptable to the patient, his or her family, or the community. Not all patients with emotional crisis are psychotic, nor are we all violent patients experiencing a psychiatric condition. These are common misconceptions. Various medical conditions can cause a behavioral crisis, e.g. hypoglycemia, hypoxemia, or brain tumors. So depression and schizophrenia are examples of A, unlike an organic disorder, a functional disorder cannot be linked to any physical dysfunction or failure of an organ. Depression, schizophrenia, obsessive compulsive disorder, OCD, and bipolar disorder are examples of functional disorders. They are usually caused by a chemical imbalance in the brain, not a structural or physical abnormality. So when assessing a patient with a behavioral crisis, your primary concern must be so what's the first and second thing you do for every call? PPE and scene safety. Whether the patient will cause harm to you or your partner. So D, there are many things that should be considered when assessing a patient with a behavioral crisis, including all the items listed in this question. Your primary concern, however, must be the safety of yourself and your partner. So general guidelines to follow when caring for a patient with a behavioral crisis include all the following except So B, when caring for a patient with a behavioral crisis, the EMT must be prepared to spend extra time with the patient. It may take longer to assess and listen to the patient prior to transport. So reflective listening. An assessment technique used when caring for patients with an emotional crisis involves So D, reflective listening technique in which you repeat in question form what the patient tells you, allows the patient to further expand on his or her thoughts. It also helps the EMT gain insight into the patient's situation. It helps the patient know that you are listening and that you want to help. Reflective listening is a good idea for patients who are experience psychiatric or behavioral emergencies. So which of the following patients is at highest risk for suicide? Remember that table we looked at? What are the risk factors involved for people who possibly may commit suicide? So C, situations or indications that place a patient at high risk for suicide include, but are not limited to, recent diagnosis of a serious illness, financial setback, marital discord, death of a loved one, untreated psychiatric illness, recent acquisition of items that could cause death, such as gun or knife, and chronic alcohol use. When caring for a patient with emotional crisis who is calm and not in need of immediate emergency care, your best course of action is to So remember what you guys have to obtain from every patient. So C, just because a patient experiences an emotional crisis does not mean that he or she is not mentally incompetent and cannot refuse EMS treatment and or transport. You should attempt to obtain consent from any conscious patient unless he or she clearly does not have the decision-making capacity, e.g. underage, altered mental status, alcohol intoxication. So when physically restraining a violent patient, the EMT should remember, you want to talk to your patient about everything, even alert and oriented patients. Let them know what's going on. Let them know what you're doing so they understand. So A, when physically restraining a violent patient, the EMT or his or her patient should continually talk to the patient throughout the process. Treat the patient with dignity and respect, regardless of the situation. Once restraints are placed, they should not be removed. Even if the patient appears to be calm, circulation in all extremities should be monitored, regardless of the position in which the patient is restrained. You're never going to place a patient prone on the gurney. It's an absolute no. They're always going to be facing upwards, so you can monitor their airway. So upon arrival at the residence of a young male with an apparent emotional crisis, a police officer tells you that the man is acting bizarrely. You find him sitting on his couch. He's conscious but confused. He takes medications but cannot remember why. His skin is pale and diaphoretic, and he has no noticeable tremors to his hands. You should first rule out. So what are the common causes that patient might be altered? What are the medical causes that patient might be altered? So A, numerous physical problems can cause bizarre behavior such as hypoglycemia, hypoxemia, and brain tumors, among others. The EMT should rule out an underlying medical cause first. The patient's pallor, diaphoresis, and motor tremors suggest hypoglycemia. The EMT should assess the patient's blood glucose level, if trained to do so, and consider administering oral glucose. Psychiatric illnesses such as clinical depression and schizophrenia cannot be ruled in or out in the field. So which of the following signs is least indicative of a patient's potential for violence? What kind of factors are you guys looking for that the patient can become hostile or aggressive or violent? So B, when assessing a patient's potential for violence, you should observe for suggestive physical activities such as clenching the fists, glaring eyes, shouting obscenities, and rapid disorganized speech. There is no correlation between a patient's physical size and his or her potential for violence. Just because you guys have a bigger patient doesn't mean that they're going to get violent with you. Look out for these signs that are going to tell you possibly patient may become violent or agitated.